a medical expert's guide to physical changes in the final stage of life. A comprehensive guide for families and caregivers. Hello, I'm a medical expert who has worked in the fields of geriatric, medicine, and palliative care for 30 years. Over the past few decades, I've met countless elderly individuals and their families, and have seen many cases where a lack of understanding of the physical changes that occur at the end of life has led to unnecessary pain and confusion. Today, based on medical evidence, I'll systematically explain the natural, physical changes that an elderly person experiences in the final stage of life. These are not signs of illness or emergencies, but rather normal biological processes of the human body. Listen to this story until the end. You can reduce medical bills without medicine and hospitals. Furthermore, the rest of your life can be completely transformed. I have a small favor to ask. If you want to continue receiving more health secrets, please hit the subscribe button right now. Likes and subscriptions are free, but the value of your health is worth more. Also, please leave the number 1 in the comments. Your single click is a huge support for video production. Please share this with your loved ones as well. Your experiences can help many people. According to global research, about 85% of people aged 65 and older experience a similar pattern of physical changes at the end of life. These changes typically appear gradually over several weeks to months. While there are individual differences, the basic sequence and characteristics show a consistent pattern. The 5 main areas we will cover today are decreased nutritional and fluid intake, altered consciousness and sleep patterns, respiratory changes, circulatory decline, and elimination dysfunction. Stage 1. Decreased nutritional and fluid intake. The decrease in appetite at the end of life is due to physiological changes, such as a lowered metabolism, hormonal shifts, a decline in digestive function, and a reduced function of the brain's appetite center. Clinically, it starts with a 50% decrease in food intake and the selective refusal of certain foods over 1 to 2 weeks. After 2 to 4 weeks, daily fluid intake drops below 500 milliliters. In the final 1 to 2 weeks, there is a complete refusal of intake, and dysphagia, or difficulty swallowing, occurs. Forcing food intake is not medically recommended, as it can lead to complications such as aspiration, pneumonia, indigestion, vomiting, and diarrhea. Instead, it is better to provide oral care to prevent the lips and oral mucosa from drying out. Offer small amounts of food by the teaspoon when desired, and allow them to experience the taste or aroma of foods they used to enjoy. The need for intravenous fluids should always be discussed with a medical professional. Stage 2. Altered consciousness and sleep patterns. Changes in brain function are caused by several factors, including reduced oxygen supply, metabolic changes, alterations in neurotransmitters, and electrolyte imbalances. Initially, a mild cognitive decline, characterized by a loss of focus and short-term memory problems, can appear 4 to 8 weeks prior. 2 to 4 weeks before the end, a moderate decline in consciousness is seen, with the person sleeping 12 to 16 hours a day, and a reduced ability to recognize time and place. In the final 1 to 2 weeks, the person enters a state of profound decline in consciousness, sleeping 18 to 22 hours a day and showing minimal response to external stimuli. These changes are not dementia, but a brain strategy to conserve energy. The brain concentrates energy on essential brainstem functions, like breathing and heart rate, and gradually shuts down higher-level cognitive functions. Common symptoms include delusions and hallucinations, such as seeing and talking to family members who have passed away, a loss of a sense of time, and a decline in language function, making it difficult to find words. Do not try to forcefully wake them. Respect their natural sleep patterns. Maintain a quiet and stable environment, and use simple, clear language when communicating. Providing emotional support by holding their hand and speaking gentle words can be very helpful. Stage 3. Respiratory changes. As a person approaches the end of life, several changes in respiratory function occur. Cheney-Stokes respiration is a pattern of progressively faster breathing, followed by periods of apnea lasting 10 to 30 seconds. This is caused by a decline in the function of the brainstem's respiratory control center, and typically appears days to weeks before death. A death rattle, a gurgling sound, caused by secretions in the bronchi, may also be heard. This is a result of a weakened swallowing and coughing reflex. Most patients are not aware of or bothered by this. Breathing rates also become extremely irregular, ranging from 6 to 40 breaths per minute, Far from the normal range of 12 to 20, the depth of breathing also becomes erratic, with shallow breaths alternating with deep ones. When dealing with respiratory changes, it is crucial to know what not to do. Attempting to forcibly remove secretions with a suction device should be avoided as it can cause discomfort to the patient. Instead, it is better to appropriately change their position to help. The secretions drain naturally. As oxygen therapy may have limited effectiveness, a medical judgment that prioritizes the patient's comfort is necessary. Stage 4 circulatory decline. As heart function declines, cardiac output decreases by 30–50%, and blood pressure drops to a systolic pressure below 90 mmHg. This leads to a concentration of blood flow in the core of the body, causing the limbs to become cold and pale. Clinical symptoms progress gradually. Weeks before, the tips of the limbs start to feel cold and pale. Days before, this spreads to the wrists and ankles, and cyanosis appears. In the hours or a day before death, this spreads to the elbows and knees, and a blotchy form of cyanosis, known as mottling, appears on the skin. These changes can be evaluated by a medical professional, who may observe that the capillary refill time is prolonged to over 3 seconds, that peripheral pulses in the radial and dorsalis pedis arteries are difficult to feel, and that the temperature difference between the core and the periphery is more than 3 degrees Fahrenheit. Since the patient's ability to regulate body temperature is compromised, using electric blankets or hot packs can pose a high risk of burns. It is safer to use a light blanket instead. Stage 5 elimination dysfunction. Kidney function declines, with the glomerular filtration rate dropping by 50–70%, and the ability to concentrate urine or regulate electrolytes is lost. At the same time, bladder capacity decreases and sphincter control is lost, slowing the urination reflex. Initially, nocturia, waking up at night to urinate, increases, and the patient may feel like they haven't completely emptied their bladder. In the intermediate stage, urinary incontinence occurs and urine output decreases. In the final stage, the patient may experience oliguria, daily urine output less than 400 milliliters, or anuria, almost no urine output. The urine's color changes from a deep yellow to a brown, and its smell becomes stronger, with ammonia odor increasing and its specific gravity rising above 1.030. The decision to insert a urinary catheter should be based on the patient's comfort. Regular repositioning is necessary to protect the skin. Careful personal hygiene is also needed to maintain the patient's dignity. Comprehensive expert guidelines. Points of communication with medical staff. The best time to request a palliative care consultation with a medical professional is when 2 or more of the symptoms described above appear simultaneously, when the patient's functional status declines rapidly, or when frequent trips to the emergency room become necessary. Furthermore, connecting the patient to hospice care can be considered in the following situations: when a life expectancy of 6 months or less is diagnosed, when the patient's comfort is prioritized over aggressive treatment, or when care at home is desired. Families should be educated on how to distinguish between an emergency and a natural process, how to manage pain, when to contact medical staff, and the importance of creating an advance directive. Do's and don'ts. When caring for the patient, it is important to regularly assess and manage their pain. It's also vital to prevent infections through oral care and to regularly check pressure points on the skin. Above all, it is crucial for all family members to provide warm and emotional support to the patient. Conversely, actions like force feeding or administering excessive fluids should be avoided. Refrain from unnecessary invasive tests or procedures, and try to avoid caring for the patient in a noisy environment. Additionally, it is essential to be careful that family conflicts do not affect the patient.